Alrighty, I think just in the matter of time, Sandra, if you're ready, I'll get us started.
That'd be great.
Yeah, welcome everybody. Welcome to our nursing rounds. I'm very excited to be here with my good friend and colleague, Sandra Lauk. And before we get started, I just want to take a moment to acknowledge that the School of Nursing and Providence Healthcare are situated in the traditional, ancestral, and unceded territory of the Musqueam, Squamish, and Tsleil-Waututh nations. And as we evolve in this presentation, and the work that I'm doing, I'll be speaking specifically to the Central Okanagan. So I would also like to acknowledge with gratitude that the work that I'm going to be talking about is coming from the unceded traditional ancestral territories of the Syilx Nation. And Sandra and I have been bouncing around ideas today, and we're going to share with you some of our perspectives and our experiences with knowledge translation. And for those of you who don't know me, I'm Vicki Bungie, and I'm a professor here in the School of Nursing, and also hold a Canada Research Chair in Gender Equity and Community Engagement. And I'll let Sandra introduce herself, but I will start by saying Sandra and I have known each other and worked together for, I forget how many decades, so I'm just not going to say it, and we'll go from there. So thanks, Sandra, so much for agreeing to do this with me, and I will hand it over to you to say hello and get us going.
Thanks, Vicki. And it is a real joy for you and I to reconnect, to do something that matters a lot to us about how do we lead nursing practice and transform the way we care for people. So my name is Sandra Lauk. I hold a dual appointment as an associate professor here at the UBC School of Nursing, and then as an embedded nurse scientist at St. Paul's Hospital. And I'm very privileged to hold the St. Paul's Hospital professorship in cardiovascular nursing at UBC, and am able then to share my attention and commitment to both organizations to help bridge some of the gaps between research and practice. So this topic is clearly near and dear to our hearts, and we're really happy this afternoon to spend some time discussing with you these concepts around how to mobilize research to lead nursing practice and improve outcomes. So we thought what might be helpful would be to highlight some perspectives on knowledge translation and kind of lay, some ground around that. And then between us to discuss 3 examples of KT in action, and then hopefully to open then the discussion to explore some opportunities to strengthen knowledge translation activities in nursing and beyond. So I'm particularly pleased that we have a new initiative that's come out of UBC to accelerate knowledge translation. And I was very pleased to be named as one of the inaugural UBC Knowledge Exchange and Mobilization Scholars as part of a program that UBC is leading with that raised awareness of the kind of the imperative and the importance of expanding and enriching public discourse and enhancing policy and practice through scholarship, to really wanting to foster university-wide culture of knowledge exchange and mobilization, and to then advocate also for structural changes so that this type of work is valued across the university and across our communities. So I'm pleased to do some of this work with my colleagues across the School of Social Work, so Dr. Barbara Lee, Dr. Jasmine Ma, who's in kinesiology, and Dr. Michelle Stack, who's in education. And together, supported by Jen Creighton and her team over at the UBC Knowledge Exchange Program, really wanting to do these 2 things about advancing the art and science of knowledge exchange and mobilization, and then importantly, accelerating the practice of those activities. So some of my work is now fortunate to be supported by this initiative. So what we set out to do as a collective was to aim to develop capacity among faculty, staff, and importantly among students as well, to model collaborative and interdisciplinary approaches. So importantly, our schools coming together to highlight the importance of building a common language across disciplines, because words matter, and how we do this work, we can leverage our collective expertise, and then to really work to establish knowledge exchange and mobilization as a central component of the work that we do at UBC and across our partnerships. So I think that's a really exciting initiative, and it speaks to UBC's commitment as well to provide some infrastructure and support for this type of work. So in keeping with one of those objectives about building a common language, Vicky and I thought it would be helpful to just kind of place some of this work within how we think about knowledge translation, and particularly in the discipline of nursing. So there is that need to close that gap between what we know and what we do. Vicky and I were both raised in critical care, where sometimes a happy shift is a patient lying supine with the head of the bed at 30 degrees, the pumps to the left, the Foley to the right, and maybe a nice quiet day where we practice, what I like to call ritualistic nursing, which is not always evidence-based nursing. So knowledge exchange and mobilization is a way of getting new evidence into use with that idea from bench to bedside. It's also importantly around increasing the impact of the research in terms of ensuring that we have, high value research, that we facilitate uptake, that we are able to scale and spread some of these initiatives, and also use this as a strategy to drive, call it patient-centered care or equity-based care by establishing these partnerships. And we're going to hear more about that later on. So just as a kind of like the beginning concepts, these are slides from the Michael Smith Health Research BC, where they state that KT activities aim to close that gap between research and implementation by improving the use of research evidence in practice, policy, and further research. And then CIHR and SSHRC have aligned their definition to talk about a dynamic and iterative process that includes synthesis, dissemination, exchange, and ethically sound application of knowledge to improve the health of Canadians, provide more effective health services and products to strengthen the healthcare system. So I expect this is not new to any of you, but I think it is important to agree on some basic definitions as we move forward with this work. Knowledge mobilization in of itself refers to a number of activities and terminologies, but I think for the sake of today's discussion, really talking about KT as this all-inclusive concept might be helpful as a starting point. This is a paper that we were fortunate to work with cardiovascular international collaborators, where we talked about how do we accelerate a knowledge translation, is particularly in the cardiovascular field. And we proposed to look at this with kind of two lenses, the practice of KT, but also the science of KT. And this, I think, to me is a helpful framework as I think about my work, just starting with the practice of KT, which could be the activities undertaken to close that gap, to move evidence into practice, and then those strategies to adopt and integrate evidence. Then looking specifically at integrated KT and end of grant KT, which have slightly different, they have different goals. Integrated KT, Vicky's going to talk about that more in detail, but it really is around that meaningful engagement of knowledge users along every single step of the research process. And then end of grant KT, which those of us who write research grants are really familiar with, but it is that ensuring that researchers are able to then translate their findings so that knowledge users, again, who are the main clients of research, are aware of and use new knowledge in decision making. And so through this, various activities such as synthesis, dissemination, exchange, and application can take place. And I think when you compare and contrast these two concepts, end of grant KT is really around that dissemination, that implementation. It's oftentimes researcher driven. It's an obligation we have. It's a thing we want to do. It's a pressure there is, and it's not typically fully planned early. Whereas integrated KT is really more team driven, and it is along the entire spectrum of research and often pre-planned because it's such a core component of the research design, as we're going to hear about shortly. So in the KT Science, then, the goal is really around the study of the methodology and approaches to promote the uptake. So it's looking at the barriers and facilitators, but why change can be so hard to introduce in whatever setting, so that knowledge producers and users understand how evidence can be successfully integrated in practice. And again, a number of activities that can help really foster that scientific understanding of how do we make change happen over time. So we've got an acute problem of wasted research. I think there's a lot of evidence to know that research resources are often wasted. This may be due because they are either low priority questions, because we haven't partnered with the right people to ask the right questions. Maybe important outcomes have not been assessed. There is that terrible statistic out there that it sometimes takes 17 years from bench to bedside to bring our meaningful and good research to practice. And that of all of the projects that take place, many are not published, they're not usable or replicable, and they may have serious design flaws. That in that process of implementation, there are unaddressed barriers to implementation. And the absence of partner engagement can be the kiss of death for very good ideas that could have gone somewhere and do not reach any degree of fruition because of those challenges. And then, of course, the challenges in measuring impact. So having established kind of like that groundwork around what we're talking about, maybe handing it over to Vicky right now to talk about an example of the work that you've been leading. You're muted, Vicky.
You think it was my first day on Zoom. But anyway, to let people know, we had a bit of a panic. I couldn't get on Zoom for some bizarre reason. So I was 1 minute before we opened the screen. So, but thanks for going first, Sandra. So here we go. So I'm going to draw on some of those big ideas that Sandra was talking about around what does integrated knowledge translation or integrated knowledge mobilization look like. And to do that, I'm going to give an example from a study that I am currently involved in, and just kind of talk about what IKT looks like in terms of how we even set up for an intervention and the kind of final decision making around what the intervention will look like that we will be studying, and how that kind of fits into this world of building on existing evidence and thinking about different sources of knowledge and that kind of thing. So just to give a little bit of background, the project that I'm talking about is called the Scaling Up Project, and it is a 7-year CERC-funded study that is looking at building the capacity of various programs to engage in outreach to help address barriers to health and social care for people who are experiencing violence or affected by violence. And so within this study, which has a lot of kind of interesting things around how we do partnerships and how we think about implementation and complexity and that sort of thing, there is this 2-year intervention kind of study, and the specific questions for that are really looking at how effective is the outreach intervention to achieve participant trust, because we know that in the context of relationships, particularly in an outreach setting, that trust is the cornerstone for sustained engagement. And how effective is this intervention to facilitate participants' engagement in health services, social services, and legal services, and also in achieving safety plans for people's material, psychological, and physical safety. And because we're embedded in complexity in this idea that the environment, be it the individual, the social, the structural kinds of pieces of the world that in which we do research in these real world settings, we're really also looking at the environmental factors that enable or confound the success to achieve it. of the intervention success to achieve its aims. And so particularly, I'm going to talk about one of the sub-studies within this is called the Chloe Project. And it is really about today just talking and walking you through how we actually use these principles and practices of integrated knowledge translation to tailor a specific intervention that has been, empirically derived. How do we tailor it to the local context, and what do we mean by tailoring, and how do we tailor that, and who's in the room and what kinds of knowledge are in the room as we make those kinds of decisions. So in this particular study, I'm talking about a partnership with organizations in Kelowna that are really looking at how to put an outreach intervention in a community in which there's a lot of gender-based violence, there's a lot of intimate partner violence, and how do we think about what would outreach mean to people who are affected by gender-based violence in their specific community. And so in thinking about IKT, it's thinking about at that outset, what are the different ways that we come to know and understand things? And so
you got time, or you have to go somewhere?
Somebody's on. I'm just
sure I know that. Yeah, I've just been booking flights and
it's just somebody who needs to mute still.
Thank you. That's okay. Thanks. Those things happen so easily. So in the beginning, it's about the evidence synthesis and feedback loops and what we call epistemic flexibility. And in that, it's to do these kinds of things, it's everything from, in this context, a solid scoping review of the literature around outreach, what makes outreach effective, what does it look like in different environments, what are its elements, what are the good indicators of success, how do we measure them, and thinking about that kind of building from the existing evidence of what is there and what we know, and also building on a program of research that's really about how do we engage with folks experiencing violence and what are the effective ways to do that. And so in this kind of context, what we did is we came together and we looked at pilot data from previous pilot studies and what are the results. And that was the Strength Project, which occurred in a very specific context within street engagement and street involvement, which looks different than other contexts for violence and that sort of thing. So in doing that kind of thing, it's about what's the evidence, what other research have we done, what's pilot data looking like, because the evidence base around what makes outreach effective is not that strong, it's not that solid. So which is one of the reasons that we did a pilot study. And then it's about what are the different sources of knowledge in that. And so one of the things that's vitally important is that in addition to our evidence knowledge and research knowledge, I'll use it in that term, is also the experiential and local knowledge for people who are engaged, working in, living with the kinds of issues that we're trying to tackle in the research that we're doing, and how we're trying to advance the practice to actually mitigate the effects of violence and to foster recovery for people. So it's all that different kind of melting pot and mushiness of all these different people and ways of being and knowing, and our research evidence that kind of comes together to help us understand. And it's not a one and done. These are very iterative back and forth loops of communication. And in that, one of the big things for us is community leadership and engagement. And what that is that taking this kind of research knowledge, what we know about our current evidence, and working with community leadership to really figure out what it is that is the local context of their setting, and how do we do that? What are the local contexts of services and supports? Who's providing them? Who's doing what? And kind of how do we figure this out in terms of not just what's happening in the setting, but how do we use that understanding of context from these various groups of stakeholders to actually really zone in on what would make an intervention effective and what it would take to be ready to go to an intervention to actually try and test this in this specific setting. So in this vein, we did all kinds of things. So we met with the groups, we talked about the current evidence around outreach, they told us a lot about their services, but we got very systematic in this as well. We did a we looked at census data and kind of what I call demographic data to kind of understand a bit about who's in the community and what the community looks like. And here is just some of the key things that we took into consideration when we were thinking about where and how this is going to happen, particularly in the Central Okanagan. So we know the Central Okanagan is the fastest growing area for population in Canada right now. I don't know after the forest fire season that we had last year that it will be that, but it is having rapid growth with very little expansion in services and resources. And we know that in times of intense growth, particularly not-for-profit services get hammered with regards to the kinds of things that they can do. About just over half of the census data shows us that half the population are women with an average age of 45.2. So we've got a very diverse kind of population. It's a growing population and aging. People tend to live the life expectancy in the Okanagan is longer than in some other parts of BC. We have a very complex and diverse history of colonization in the area. And there are many Indigenous people that represent about 5.9% of the overall population, which is compared to places like Vancouver, it's about 2.2%. So a lot of what's happening in terms of Central Okanagan is very grounded within Indigenous health and well-being centers, legal services, and those kinds of things. The drug toxicity crisis is impacting this community as it is all communities across. And the one thing that is really interesting to attend to is that it has the highest crime rate in Canada, which a lot of people don't know, and that kind of thing. And when you're working in the area of violence, these kinds of things are really important to nuance down how that plays out in sort of the violence and victim services sector. So we did interviews with staff, we did all these kinds of things that we did interviews with women who attend to services and really zoned in on working with what we call a lead organization, whereas an organization that has the greatest chance of success if you embed a new intervention, that it has wraparound supports and services to help facilitate and foster the success both of the intervention and to be a value added to the organization in terms of the kinds of services they're trying to improve and expand within their own programming. And so just to, learning this is learning so much about the organizations and the people that we work with. And so this was really getting in to understand how this organization, the Central Okanagan Elizabeth Fry Society, is trauma informed with a very particular focus on empowerment and strength-based approaches, with very committed policies and procedures around the goal of not re-traumatize folks. The other piece is they hold the victim services contract for the Central Okanagan, which means that anybody who's engaged, particularly with the criminal justice system due to an assault, be it through intimate partner violence or sexual assault, is an automatic referral into their services and resources. And others, just really understanding the strengths that we're working with and having these kinds of conversations back and forth around what this works, is that recognizing that we're embedded in an organization that is very proactive. It's committed to evidence-based practice. It has a mandate and goal not to duplicate services, which we see a lot in research and community settings. We see this kind of duplication of things. And that they really wanted to build on and expand on the fact that they are the leader in victim services within the locale, and also do a tremendous amount of advocacy and education and support for the other organizations that they work with. And they have a long-standing and very positive working relationship with local law enforcement, which doesn't always happen for victim services in terms of getting the supports and services that people need. So the other piece that just to highlight is that the organization is incredibly adaptable and flexible. The organization saw 500% increase in demand and services throughout the pandemic. And so their ability to flex and adapt and respond and integrate evidence on the ground makes them just this kind of like ideal partner or dream to kind of work with. And so the other piece that we sometimes forget, so not folks who do patient engagement, is about it and how do women experience the services, and what does that mean in terms of an integrated KT approach to really finalizing what the intervention design should look like. And so we talk to women within the community locally and a bit scattered. The central Okanagan is quite a scattered region. And so really to understand what it looks like to access services in this area, both from health and social care, be those urgent primary care, to, as we said, the not-for-profit sort of supportive services that are there. And like any kind of context, we see again services are centralized into a downtown core when in actual fact they're serving quite a large, hundreds of kilometers square in terms of the people that they're trying to reach and try to serve. And we can see the impact that travel and those kinds of things has. And this is important because this also tells us what we need to do to make an intervention successful and to ensure that we're reaching the people. We're more inclusive in our approach and how we do our research to ensure that we're reaching all people who this would be of relevance and benefit for. And so you can see that, again, we see this alignment between women's perspectives in the organization around this recognition. We're not perfect, but people can help. People are always there. People get a follow-up. So understanding that we need to ensure that whatever we put into this organization as research, and as we're partnering to do this, that we build on the strengths and we make sure that we don't jeopardize the positive relationships that the organization has within the community. So whatever we build, we need to continue to ensure that it is consistent, it is compassionate, it is knowledgeable, and it is flexible and adaptable to try and meet women wherever they're at, which was really great for us because that's sort of the core principles on which the overall intervention was developed. And so this is just a very quick kind of snapshot of, through working with this organization and working through our pilot data and other adaptations, we were all able to come together and understand this is our model of outreach. This is Chloe, as we call her, and this is our community-led outreach and engagement model. And we have these guiding values and principles that speak to the rights to self-determination. They speak to the importance of harm reduction. They also speak to trauma and violence informed, culturally safe, and really this integrated service model in which, as we said, it's value added and not disrupting or duplicating what's currently on the ground. And we also developed this continuum because we know that when women, I'll just use an example, when women are leaving perhaps a violent relationship and they attend to any type of shelter or services, there's often a 30-day maximum that they have within the context of those. And or women come into the system at various entry points, and sometimes it's understanding where they're at in their journey and what they're ready for. And so we have this model of this kind of continuum or spectrum of being able to do what we call this immediate on the ground sort of stuff, and this more sort of with the idea that women are starting to connect into services, and maybe we can start to build relationships where they can engage with other services over time. Or sometimes women come in fully ready to do a lot of things, and they need someone to really help navigate the multiple different systems and services, and they tend to be longer term, but that we needed something that wasn't exclusionary, that could meet people wherever they were at in their own journey within their experiences of violence, and that we could be useful in that kind of end and build on, as I said, what was existing. So this is kind of this, but this IKT is where it really, really kind of comes together. We've been working together, we've been reading, we've been talking, we've been, doing all these things, but when it comes down to really, are we going to go live? Are we going to do something kind of thing? It's how well aligned is the research and theoretical frameworks with the organization? What are the existing gaps in services? What gap can Chloe, this outreach model, fill? What will it contribute to the evidence-based practice that people are growing or using their programs to use to inform the growth in their programs and services? And how will it contribute in a responsive, respectful, and meaningful way to these services that respond in the context of gender-based violence? And so this is the work of IKT in terms of getting ready to go, is that really looking at those kinds of things that are aligned, where those sticky points are, or as Phoebe calls it, one of the research managers, Phoebe Long, who I think is on the call, our pinch points, where we can get stuck in those kinds of things. And you know, it's an amazing thing when you see you've done all this work, and I'm going to acknowledge it takes a tremendous amount of time and effort, but if you could see where we are today, and what's happening on the ground, it's so worth it. And so what this has contributed to is what we have now in moving out of pilot research into different types of case-based analysis intervention studies that are not amenable to any type of RCT on the ground and that kind of thing. But what we have is an actual explanatory model that is community-driven, community-led, in full partnership with researchers, in which we can actually test an explanatory model that to actually look at, does this intervention do what we say it's going to do, and are we really clear what's within scope and outside of the scope of this intervention? And that the value of this is that we get to do this in multiple different places across Canada. And so each time we go through the same IKT process to tailor that intervention to that setting, but recognizing how we're going to do explanatory models across site. So I will end with saying where we are today, and we have launched in Kelowna, known as the Chloe Project. We are working within the full spectrum of our model of engagement. Both we're in the context of immediate crisis support, particularly for people across the full gender spectrum, age 12 and up, who experience a sexual assault, where we know that as they leave any emergency services, they're often left to their own. And so we'll be working specifically to help people transition into a safe space if they're leaving the emergency room or that kind of thing, and also starting to introduce them to what the services are that are available to them to be able to support their healing trajectory post an acute traumatic event. And we're also working across that spectrum of engagement to really dig into this gap that happens for women and families in particular when they come in through and have a victim service record associated with intimate partner violence. And what we discovered in this work is that the victim services, criminal justice system, and the family law system don't work together, and they don't talk to one another. And the victim services workers are completely, well, as you can imagine, with a 500% increase in the demand in services over the pandemic, we know that there's not enough resources to go around, that they can't do all of those other pieces that connect to ensure that women are safe in a variety of different ways and to work with them. And so our particular Chloe project focus is actually to engage with women, to provide those to outreach, to sustain engagement with women, because we know also criminal justice files can take years and years to progress, but that in this intervention, we'll be able to use outreach to engage with women across the central Okanagan, to support them through both in the family law context of preparing to attend to family law, and also all of those really neat things that we call the social determinants of health that women who are experiencing violence often have incredible challenges navigating the system to ensure safe housing, appropriate housing. And we know that it's all, there's little or no supportive housing for women in their families in these contexts, and also supporting for employment, for income assistance, and those kinds of things. But being able to connect in and work with women in one-on-one kinds of ways through outreach and engagement to figure out what do they need as they're to support their health and well-being as they're navigating this criminal justice system and the other aspects of law that impact their lives when they're experiencing intimate partner violence. So I'm going to hand it back to Sandra and just, you know, say thanks for that. And Sandra, over to you for more examples of the kind of work that nurses do when we take this knowledge mobilization and exchange hat and put it on.
Yeah, and thanks for that great example of the complexities, the time, the effort, the thoughtfulness of the work that you're leading. And I think also the incredible reward of doing this work that is truly transformative. And just going to move us on to a kind of a different version of that. And one example that's more related to acute care, and another one that's related to nursing models of staffing. So one of the opportunities I have in the unique role that I hold is that capacity to work very closely in the clinical setting to support nursing practice and promote the role that nurses play in research, and then at the university to be able to use some of the resources, the networks, and the skill set that come with that academic affiliation. And that is really the vision of this professorship, which still to this day is the first in Canada. And I think just huge thanks to both UBC and St. Paul's Hospital for believing in the work that can be done to promote the role that nurses play to improve outcomes and health services. Because I think one of the unique opportunities of these roles as agents of KT is to work very closely with the powerhouse of practice close nurses who have this interest in research and have that capacity and desire to contribute to evidence. And I'm very fortunate to have a community of practice in the clinical setting where, you know, I can collaborate very closely with people who have fantastic ideas to better meet the needs of patients and health services. One of the groups I'm working with right now is the nurses in the surgical team who are managing surgical pain. And this is clearly a challenge for nursing. And I went through nursing school a long time ago. And what we learned about pain management has evolved hugely during that time. So we know that pain is a common experience in the hospital setting. It's complex to assess and it's complex to manage. It's one of those cross-cutters in terms of clinical competencies across multiple areas. It is challenging, especially in the setting of now a very novice workforce and with rapidly evolving evidence. You know, Vicky just alluded to the crisis we are facing of opioid use in the community. And some of those issues start right there in the hospital. So how can we address nursing practice in that evolving context? So this team led by my colleague, PJ Matras, who's a clinical nurse specialist for acute pain at St. Paul's Hospital, and a wealth of information around acute and chronic pain, has been working with her team to move beyond like pain is just a number. You know, I think we were all raised in that, you know, I certainly have being a cardiac nurse for many years. What's your pain between 1 and 10? Well, we know that is just not enough. And I think then at the opposite, at the end of that, the implementation of an electronic medical record where there is a plethora of assessment tools for pain has really meant that we're stuck in this pain scale world with multiple tools available to us that we are maybe not using or using appropriately. And there is a lot of questions around that pain assessment. So PG and her team wanted to know, how can we use the existing evidence to improve nurses' assessment of pain, especially looking at people's function, that capacity to get out of bed, that capacity to do their activities of daily living, and how this fits within their overall physical, mental, and social health. So this is a formidable team of expert nurses who identified this gap in nursing practice around the assessment piece and really wanting to support their colleagues by mobilizing the existing evidence to be able to change practice. And they looked at recent guidelines, which are really, we know they're foundational to the way we practice, and, noted that one of the recommendations in the updated guidelines around pain management to prevent opioid-related harm in adult surgical patients was to provide pain management, not just based on that number, but really on those functional outcomes around that capacity to attend to activities of daily living and looking at limitations in that sense. And they set out to talk about how can we make change happen, basically, in the assessment of pain in the acute and critical care environment by implementing a functional pain scale to augment nurses' assessment of patients' pain, and to really try to bring that evolving evidence to the bedside, looking at effective strategies to implement surgical nurses' standardized and sustained use of a functional pain scale in their practice. And this is where I think leaning on, roadmaps basically on how to do this. And many of you will be familiar with the knowledge to action cycle. It's one of many ways to kind of set out the steps that are required for the process of translating research into practice. Again, this is the work of Ian Graham and many others to be able to demonstrate or to provide some suggested goals around how do you mobilize the knowledge that you have and then go through what is, as Vicky nicely described, a very complex and iterative process to be able to change practice, as opposed to, maybe theories that might be looking at describing prediction and causal mechanisms and frameworks that might be wanting to explain the factors that influence implementation outcomes. And I've certainly found in my research practice at the hospital using this knowledge to action cycle to be just a solid little piece of branch to hang on to as we move through the process. And again, a shout out to my colleague, Liz Doherty, who's a clinical nurse specialist at Providence, who does work around caring for people with addiction, around some of the things that we need to do to be able to be agents of change within the hospital. So that ability to establish trust and engage and involve individuals in the change process, being respectful, patient, flexible, etc., having that credibility, that enthusiasm, that thick skin that it sometimes takes to make change happen in clinical practice, and then the skills in organization. And I think this is very similar to some of the messages we heard from Vicky's project. And then lastly, another example here around using evidence to strengthen the role of clinical nurse specialists. This is another area that I am passionate about championing the role that advanced practice nurses play across the spectrum. And many of you will know that a CNS is a nurse, a registered nurse who has graduate education in nursing, who has specialized knowledge around population-based care. And I know there are some CNSs on the call today who will recognize that the competencies that are required to operate across the domains of practice of advanced clinical care, system leadership, advancement of nursing practice, and then evaluation, research, and KT really speak to the unique nature of this leadership role, not so much as leading operations, but really leading nursing practice. And I think, again, this might be a little bit simplistic, but I think for those of you who may not be familiar for the role, this is a slide that my friend Martha Mackay put together to kind of give a snapshot of some of those differences between the two advanced practice nursing roles that are recognized in Canada, the CNS and the nurse practitioner, where the CNS is really working at that system level, at the edge of innovation to transform the way we provide care. So we had a unique opportunity where BC Cancer, where, as you know, as part of the BC Cancer Plan, is really enacting a lot of interventions to improve cancer care across the province. And to their credit, they recognized how the role of the CNS, which has really eroded, I would say, in many health authorities across BC in the last couple of decades, could play an essential role in activating that BC Cancer Plan. And so there's certainly a sense that as the largest segment of the Canadian healthcare workforce, nursing has been disproportionately affected by what we're seeing every day in care, the escalating health human resource crisis. That in BC, there is a renewed interest in the CNS workforce as a group of expert nurses who can make those who can help support systems transformation. And that we also know from the evidence that across Canada, CNS roles have been underdeveloped, optimally deployed, and vastly underutilized. A lot of this evidence has come from Ontario, with very little of that research being done in BC. And we were lucky to be awarded a CIHR grant then to look at an IKT again initiative to develop clear, actionable, and evidence-based policy to shape nursing workforce transformation, and propose some practice-ready policy recommendation to establish a CNS workforce across the Provincial Health Service Authority, specifically at BC Cancer. And so my interest in this has been, I was very lucky to have the best job ever, to work as a CNS for over 10 years. And to team up with my colleague, Dr. Leah Lambert, who is the Executive Director for Nursing and Allied Health Research at BC Cancer. And we proposed, much like what Vicky described, to bring along the partners we needed to engage with to develop a policy and strategy to optimize the effectiveness of and long-term sustainability of CNS roles as essential for health equity and delivery of accessible, high quality, and specialized healthcare in BC. So I'm particularly excited about this initiative right now, because I think we have the opportunity through the partner engagement, through the close attention to this role, to propose some meaningful and transformative interventions to be able to optimize this role. So we looked at what we're aiming to do during this study is really to optimize, as I said, the long-term sustainability of CNS roles. We are very fortunate to have Dr. Natasha Prodenbala as our main knowledge user. Many of you will know her from various roles she's occupied, but currently the Chief Nursing Officer at PHSA, who again is very interested in optimizing this workforce to be able to meet the mandate of PHSA, and then working with administration, but also people who hold these roles, such as Jagvir Kaur and Scott Beck over at BC Cancer, with the support of some of our colleagues here at UBC, Dr. Thorne, Dr. Habai, and Amor McPhee as well, and then working with Denise Bryant-Lukosius, who is at McMaster University and has done some pivotal work in the field of advanced practice nursing. And then the strong support of the CNS Association of BC through Cherry Kensall, who many of you will know as well. And what we're hoping to do through this study, not hoping, what we will be doing through this study is really aligning the findings with some of the recommendations, for example, of our National Chief Nursing Officer looking at national retention to improve the working lives of nurses in Canada. And many of you will have seen this document about what is needed across interventions to be able to address the health and human resource crisis that we're facing with the nursing shortage. And with a policy output that has the potential to provide kind of like a BC voice to what ought a job description be, for example, in terms of the academic preparation and the deliverables. What could an orientation and career ladder development program look like to be able to foster strong professional development? What are the resources to support the role clarity and integration? We've heard loud and clear from many CNSs that the lack of role clarity and the lack of vertical integration across the organization is a detriment to the work that they do. And then importantly, proposing some performance and quality indicators for the work of the CNS. And through our partnerships, being able to then deliver a policy report and then proceed with some knowledge translation activities. So I hope that these three examples that we've we've discussed have given you a sense that there is a growing imperative to accelerate knowledge translation, to first and foremost increase the uptake of much needed research, to facilitate meaningful and impactful community and clinical partner engagement, and importantly, to study the barriers and facilitators of KT. How do we make this happen? I would put to you that nurses are ideally experienced in being knowledge translators, be it the practice of KT or the science of KT, because we are the ones who spend the most time in that space between the stretcher and the curtain, in the clinic group, on the streets, trying to understand how do we promote that meaningful change. And again, for those of you in graduate school or early in your career or in clinical practice, I think that there are incredibly exciting opportunities to develop innovative and important KT roles that will augment the clinical care that we lead, but also the scholarship. So we were hoping now to have a little bit of a discussion, maybe some questions, some comments about what we presented, and happy to take it in the chat, or, you know, we're a small room, so can raise your hand, and maybe Vicky, I'll turn it over to you to facilitate this.
Okay, thanks, Sandra. Thanks for those great examples and for all of this, and for being our champion in nursing and in the university and across the healthcare system in knowledge mobilization.